Well, good morning, everyone. Congratulations on getting here. It's the usual 5-minute academic start, and it says 10 o'clock. It actually starts at 5 past. You see this picture of James Paget here, so first prize to the person who spots a Paget in the room. So Henry Paget is over there, who's going to be talking to us later. So I think we'll just kick off with presentations, and we start with an accomplishment of the charity under the guidance of Stuart Ralston in particular, and Steve Tucker, who's not here actually today. And Mike Stone from Cardiff is going to talk about the new guidelines for Paget's disease.
It is my privilege and pleasure to present to you the new Paget's disease clinical guidelines. So this has been a long time in the making, and if I take you back to the previous guidelines, which were done in a very different way, I might add, that was back, well, we met in 2001. Two of the authors are here, myself and Stuart Ralston, and there was Mike Davey and Peter Selby. And four of us basically sat in a room at the Etrop Grange Hotel, I remember it well, at Manchester Airport, and we kind of locked ourselves in for a day, kind of wrote a chapter each, came back once more and published these guidelines. And I think they were fine, and they were pragmatic, and they were published, and they were, generally speaking, well received. And for the last, 5, maybe longer, years, we've been very conscious that there have been advances, particularly in treatments, more knowledge, and we should be updating these guidelines. And that's what you generally do. You produce guidelines, and then you would usually say, I will update these in the next 2 to 3 years. But we never did it. We kept talking about it. The prime mover for getting the new guidelines going was Stephen Tuck, who's our vice chairman, the vice chairman of your association. And it was really him that got the process going. I mean, it has to be said that Professor Stuart Ralston here did the lion's share of the work in terms of writing these guidelines, and it was a heroic accomplishment, and did it in a really quite short space of time. But what I'm going to do is take you through how we went about it. So producing guidelines now is a much more sophisticated process if you want it to be taken seriously, if you want it to be recognised by relevant organisations, and you have to do it in a very specific way. So I'm going to take you briefly, really not right up until lunchtime, through the methodology. So the guideline development group was convened, and that was back in January 2016. The lead organisation is very much led by the Paget's Association, but we were fortunate to persuade 2 other very influential organisations, which were the European Calcified Tissue Society, or ECTS for short, and Professor Ralston is a key player in that organisation, and also, with the help of Professor Cyrus Cooper, the International Osteoporosis Foundation. You may be thinking, well, Osteoporosis Foundation, how's that relevant? Well, that organisation now encompasses other bone diseases, including Paget's disease. So it's a really useful, worldwide influence organisation to have on board. And indeed, both of those international organisations have endorsed our new guidelines, which I think is really useful and a credit to the association. The group should and did and does contain a lot of different people from all sorts of professions and disciplines, as we say. So a multidisciplinary panel. Although it wasn't mentioned in the main text, I've put in gerontology or geriatrics because that's one of the things that I do. It actually isn't, I mean, you can't put every single specialty down there, but we had specialists from all different disciplines: gerontology, rheumatology, joints, endocrinology, hormones, biochemists, so to do with the biochemistry, the blood test that you have when you're diagnosing and measuring response in Paget's disease. Scientists, kind of proper scientists, non-clinicians, so people who are at the sort of more basic end of research, if you like, specialist nurse, Diana, patients with Paget's disease, Keith Simpson, who sit here somewhere in the audience, and all of those people are really important to have on your panel if you're going to develop guidelines that people will accept, believe, and use, and you want them of the highest quality. In terms of the methodology, we use this thing. It's an easy name to remember, GRADE. So in terms of sort of grading your evidence and in terms of how you express your recommendations, and I'll say at this point, it's the recommendations that most people are going to read. I mean, the document's 49 pages long, but most people, a lot of clinicians, are not going to read that. They're going to go straight for the recommendations. And how you go about reaching the point of recommendations, you have to do in a specific manner. And the manner chosen was this tool, which is widely published, validated, internationally accepted, and used by lots of different organisations. So that's what we used. You then have to look at all the evidence. And as you'll see, one of the issues, I don't know if to call it a problem, but one of the limitations is the amount of evidence out there. And it's also one of the reasons we've got quite a long list of recommendations for research to clarify a lot of the questions that we couldn't answer. But you need a comprehensive review of the literature, and that's a heroic task. And you really need a professional organisation to do that. So that's what we did. So we used a professional organisation, we paid for it, and they look at every single paper ever published in worldwide in all the different languages, etc. And you then rank that in order of quality. So top of the tree would be what we call a systematic review, and if you've got a systematic review giving you an outcome, a conclusion, that's best. Using what we call randomized trials, when you randomly allocate patients to an intervention, a treatment, versus not having the treatment in a random fashion. That's the highest quality evidence. Next would be, so a systematic review is where you've got more than one randomized trial. Next would be a randomized trial. Third would be an observational trial, where it's not randomized, you just take people with the disease, without, but you're not randomly allocating to the treatment. And it's just not as good quality data. And then lastly, you just look at a series of patients. You might take a series of patients and just observe them and look at what happens. And that's the lowest level of evidence. For the purpose of this guideline, we only looked at, because some people would produce a single case report or 2 or 3 patients. We decided only to look at a series of at least 10, so that it would be of higher quality, if you like. And then we sat down and decided on 6 key questions that we thought were most relevant to Paget's disease of bone. So question 1 was which measurements or tools work in the identification and diagnosis of Paget's disease. So how best do we go about diagnosing, identifying, picking up people with Paget's disease? So that's a really important question. And we know there are still a lot of patients out there we're missing and we're not diagnosing. So we need advice to be able to give advice on how best to do that, if we have the evidence. Then we have which diagnostic measurements tools are effective in predicting the response to treatment. So if you identify it, is there any way of deciding who is going to respond best to treatment? That was another area we thought was worth addressing. Number 3, really important question, who should we treat? So we've diagnosed it, we've identified the disease. Should everybody get treatment? Is it only those who have symptoms? Is it pain? You know, if your blood test is high, should you get treatment? Whether you have pain or not, that sort of thing. What are the effects of treatment? That's very important. So what does it help? What does it improve? Do the benefits outweigh risks? So that's really important. You've got to look at the balance between risks and benefits. Between the risks and the benefits. And that's something I'll come to. For how long should you treat? That's another key question area. For how long should you treat? And the mode of treatment means, do you give repeated courses of treatment? Do you tackle it in a manner that you want to totally suppress the blood test back into normal? Or would you accept symptoms getting better, the disease is still active? Is that just as good? You're going to look at quality of life and all that sort of thing. So that was another key question. And then, of course, there are other interventions that you could use other than drugs, and things like physiotherapy, devices to support bones and joints, exercise programs, etc. So there are other non-drug treatments that you would want to consider. So then apply to each of those key areas, we would try and reach a recommendation. In your packs, you have an A4 sheet with what's called an infographic. Everybody's got those? And it looks like some people have got laminated ones. Here, so this infographic is a very good and clear summary of the key recommendations. It also gives you a flow chart of this diagnostic process. So everybody's got those. And that's a really nice summary of what I'm going to say. And I'll put this up at the end of my talk. So, and there are various, within the main document, we have various tables, and we have our recommendations within that main document. And for each recommendation, we look at the balance between risks and benefits, the quality of the evidence, what patients think, how they value the various recommendations, what their preferences are. You have to look at cost, use of resources, and then you come out with your recommendation. We also had, was it five key recommendations? And that's what I'm going to focus on for my talk, even though I've been told I've got unlimited time. I can't go through every recommendation in detail, so I'm going to take you through what we call the key recommendations. We had a vote on this. So we had a vote, very democratic, and we came out with our key recommendations. So in terms of diagnosis, we agreed, and you've probably heard of this, that the blood test called alkaline phosphatase, or total alkaline phosphatase, which is a very readily available blood test, is the first line screening blood test when you're considering the diagnosis of Paget's disease. And for a lot of patients, that's sufficient. There was a lot of discussion about this. But if you suspect someone's got Paget's disease and you think it is active, but the total alkaline phosphatase is normal, there are more specific, specialised blood tests that you should then consider. That's what we're recommending under those circumstances. So if the total alkaline phosphatase is normal, we recommend that you consider other blood tests, one of which is a bone-specific alkaline phosphatase. That's what BALP means. The other is another blood test, which is a marker of excessive bone formation. It's called P1NP. It doesn't matter too much what it stands for, but they're more specific blood tests, which are more sensitive and might help the clinician diagnose active Paget's disease with a simple blood test. So that's our key recommendation for diagnostic blood tests. In terms of taking pictures, images, and this discussion went on for a very long time. In the end, we decided in our key recommendation to combine the two I've underlined here. So there was a strong voice of opinion that there was sufficient evidence to say you could do a set of x-rays, ordinary x-rays, and this is actually quite a big change from what we've recommended before, but we have some evidence, it's only observational evidence, hence the quality is classified as very low because you've got no randomised trials for this. But you have evidence that by doing a certain set of x-rays, not the whole skeleton, you could pick up more than 90% of patients who might have Paget's disease. And some people felt that that might be an easier thing to do for some centres and might be an appropriate thing to do first. And on your infographic document, you'll see that comes in first before the isotope bone scan. There was a lot of discussion about this, but in the end, that's what we decided to say. And when you look at the document in detail, we do say initially that we recommend those targeted x-rays. In our key recommendation, we kind of combine the two, because you've probably heard of isotope bone scans. Would that be right? Have many of you have heard of those? Yeah, some of you will have had them. And we're also recommending that it's very reasonable to do an isotope bone scan as well as the x-rays. I have to say, I mean, these are guidelines, and it doesn't mean you have to do that. And for example, my clinical approach will still be to do, first of all, and I'd be interested to hear what others might think, would be to do an isotope bone scan. So if I think someone's got Paget's disease, and I want to know whether it's active, and I want to know which bones it affects, all right, I could pick up 90% with plain x-rays. I would still rather do an isotope bone scan. And I personally would do that first. But the majority view was to go for a set of targeted x-rays, and then you can also do an isotope bone scan to look at the activity and to look at all the bones. The targeted x-rays were facial bone, skull, abdominal x-ray, and both shin bones, or the tibias. And that picked up 93% of patients in this one study. It is a single study performed in Spain. So that explains that recommendations. That recommendation. In terms of the effect of drug treatments, and again, inevitably, there was a lot of discussion around this. And for this, we had our best evidence. So we had randomized controlled trials achieving moderate quality evidence. But bisphosphonates are effective and are therefore recommended for the treatment of bone pain associated with Paget's disease. And that's quite obviously where we have the best evidence. And that's very clear, and everybody agreed with that. So if you have Paget's disease and you have bone pain, where you have the Paget's disease, then that's a very clear reason to have treatment. And everybody agreed with that. So that's an important message to send out. And in terms of which treatment you choose, we're making a strong recommendation now, and this is a big change from 2002 because we didn't have intravenous zoledronate then. The recommendation is zoledronic acid is the best treatment. It's been compared with other treatments. That's the best one. So as long as there's no reason you can't have it, and that might include kidney disease sometimes means you can't have it. But if you can have it, that's the one you should have. That is the treatment we recommend first line. Doesn't mean other treatments don't work, but we think that is the best. We have evidence for that. And in terms of pain response, which is the most important thing to treat, that's the recommendation. Unfortunately, there are still lots of gaps in the evidence. And that's something that's discussed in our guideline document. And that includes the following. This is not comprehensive, but here are some of the more important ones. So in terms of whether treatments benefit other recognised complications of Paget disease, including arthritis, osteoarthritis, which is more likely to occur where the Paget's disease of the bone is next to a joint, you're more likely to develop accelerated osteoarthritis, wear and tear, if you like, of that joint. And you're getting a talk on osteoarthritis later on in the meeting. Will it prevent fractures? If you have orthopaedic surgery in an area of Paget's disease of bone, we know that sometimes there'll be more blood loss from that bone affected by Paget's disease. Will pre-treatment, say with zoledronate, reduce that blood loss? Well, we just don't have the evidence for that to really give a recommendation. Will it prevent the very, very, very rare malignancy that you can get with Paget's disease? I've never seen a case, never, in sort of 25 years. It's very rare, and we're probably never going to have evidence for that, but we can't make a statement about whether you would reduce the risk of that particular malignancy, osteosarcoma. You kind of like to think it would, but you don't have the evidence. Quality of life, even for quality of life, we don't have great evidence. We have a little bit, or some, but not enough to make a clear recommendation. So there are gaps in the evidence. That mode of therapy business, so if you see a patient and maybe they don't have symptoms, or you treat them with, let's say, 1 dose of zoledronate and the bone pain gets better, but the alkaline phosphatase still remains high, and you'd say the disease is still active. Should you therefore repeatedly give courses of treatment to get that blood test right back down in the normal range? And the evidence for this comes from Professor Ralston's PRISM trial. So this is the biggest ever Paget's disease randomised trial, and that did not support the notion that getting that alkaline phosphatase back down right into the normal, or what we call reference range, translated into benefits. And there was a little bit of evidence, and Professor Ralston might want to comment it, that you might even do some harm if you hit patients repeatedly, treated them repeatedly with zoledronic acid. It might not be a sensible thing to do. But yeah, I mean, there's still some gaps in the evidence, and the quality of that evidence wasn't great. So the recommendation was the treatment goal should be bone pain, reduce bone pain. It's not so clear whether you should get the bone metabolism, that alkaline phosphatase blood test right back into the normal range. That again is a big change from what we were saying in our previous guidelines. And I think it reflects this is much more evidence-based. So it's an uncomfortable feeling, I have to say, when you sit there and you're sort of saying things, you're thinking, ooh, I'm not, but that's the evidence. And I think it's really important we do it in that evidence-based manner. In terms of let's have a positive message. And we think this is a really important positive message, because often people with Paget's disease are denied access for surgery that can really benefit them, including joint replacement surgery or surgery to change the shape of the bone to improve the mechanics of the joint, which we call osteotomy. You might resect a kind of triangle wedge shape of bone just to realign a joint. And we felt that there was sufficient evidence to make a recommendation that, in particular, hip or knee replacement surgery is recommended for patients with Paget's disease of bone who get osteoarthritis. So when you look at the outcomes and how people do after surgery, generally speaking, it looked favourable. So we thought that was a really important recommendation, and we were pleased to make that. So there are still lots of questions that we couldn't answer, even with that very methodical, detailed process. We still don't have clear answers for you regarding risk versus benefits. Say, for example, you have no symptoms, but you have Paget's disease, and it might still be active either on your scan or your blood test. Still a lack of evidence for longer-term complications that we've already talked about. We have the whole issue of genetic profiling. So you look at the genetics of patients with Paget's disease and do different genetics determine what's going to happen, and should it determine what you do? We don't know that. We would still like, even though we've made a recommendation, we'd still like more information on surgery for Paget's, and then we'd also like some more evidence on some of the non-pharmacological treatments as well. So we make some recommendations for research, further research in the document. The document, largely down to Professor Ralston, has been submitted to the most prestigious bone journal, which is JBMR, that's the Journal of Bone and Mineral Research, which is the journal of the American Society for Bone and Mineral Research, or ASBMR for short. They've already endorsed the document. The editor was favourably disposed to receiving our guidelines for consideration for publication. It will be peer reviewed. Lots of other experts will look at it. I'm sure we might have to make some changes, but that would be great. If it goes out in that journal, that's brilliant. And remember, it's the Paget's Association which has led this process. And then just lastly, we're well before lunch, just to put up that infographic. So one of the members on the guideline group produced this infographic, which I think is brilliant. It summarises it so well. It's so clear, and it takes you through that diagnostic process in a pictorial manner. And then you have all the recommendations and some of the summary of some of the lack of evidence, which I think is super. So I'm going to stop there. I don't know whether we want to take questions or whether we move on. And thank you for listening.
It's a great job these guys have done. And one question is, are any other groups likely to produce guidelines that resemble or differ from this? Or do you think everybody else would just not want to do anything at this point because you've done such a thorough job?
I think the short answer to that is no, because we are getting very favourable responses. And as some of us remember, there was a lot of controversy when we produced our guidelines back in 2002, particularly from North America, and some other much less evidence-based guidelines have been published which differ from ours. But I think it's fair to say, I don't know if Stuart agrees, we've been very pleasantly surprised, perhaps, but pleasantly surprised that the general opinion is very favourable. People do like these guidelines, and it's great for the association to have led this process. I think it's fantastic. It's great publicity.
Yes, a question.
The question is going to relate to the guidelines. The question is relating to the guidelines, because prior to coming to the meeting, I had a look on the NICE website to see what there was on NICE. And I am on the distribution list for guidelines for NICE. The only guidelines that I can see are the BMJ guidelines that were produced at the back end of 2017. And I wondered if there was any prospect of NICE taking this on to do a thorough guideline.
So I think probably not. I mean, it's not something we've discussed yet. I mean, it's an interesting comment. And one of the issues here is because we don't have that many randomised controlled trials, that might trouble NICE if they're going to look at this. I think we might get in through the primary care route. I think that's something. Yeah, well, we haven't discussed that. I think it's a really good suggestion.
I really
of course, I've forgotten what they're called. You interact with NICE with your Scottish osteoporosis guidelines, and you got it into. There's a terminology for it. So you have a kind of more pragmatic, perhaps less evidence-based, but a realistic, sort of quick, digestible set of guidelines, which will be NICE endorsed and go on their website. It's aimed mainly at GPs, primary care doctors, but nevertheless, it might be, a really useful thing to consider. The BMJ thing, that was just a best practice document, so they're not really guidelines. But yeah, people look at them, but that was nothing like this, and would rank way below this. But NICE, yeah, maybe we could. It may be, I don't know, Stuart.
Well, you can get them to. Right, basically NICE can endorse your guideline if you've done it according to the correct processes and your patient involvement, which we have actually. Yeah. So, and I think we have done all of that. So I think that would be the route, because for them to start from scratch, it's like reinventing the wheel. What would be the point? So I think that could be worth exploring once we get this published.
That's a very good suggestion.
Yeah, thank you.
One point is that with NICE, so often they're preoccupied with the cost of drugs and so on. And the drugs in this area are dirt cheap, basically, aren't they? Would you be happy with that statement, Stuart?
Yes.
The price of drugs is not a deterrent to their use. So that's important.
Absolutely.
Any other questions? I think it's useful to have the questions that are coming, and thank you very much for yours. Please.
Just to build on that point, so if we look at these guidelines, I'm right in thinking that they're aimed at a high level of medical audience, whereas I think where we were going with the other question was when you get down to the front line of GPs, where we know the awareness of Paget's is low. So what we could expect is an adaptation, simplification of these guidelines, which arguably are high level, as it gets nearer to the GP level. Is that correct?
Yeah, there is, but that's partly why we have the infographic, which would be very GP friendly, and of course we have the key recommendations. But yeah, I think that's a fair comment. Yeah.
Okay. Any other questions?
Can I just make one more comment in relation to that? One thing we actually did discuss at the guideline group is making a cut-down version of the guidelines, like a summary basically. And sometimes the BMJ run those as Mike has said, this guideline is very exhaustive, 200 references, 48 pages, but we thought we could make a much cut-down version with that kind of headlining it, and maybe try and get it published in BMJ or a journal that GPs are going to read. It's much more easy to digest, but once we finished it,
huge sigh of relief. Yeah, no, it's
Who's the audience? Is the question.
Exactly.
The audience exists at different levels,
Exactly.
with different amounts of time and knowledge.
That's exactly the reason for having the more abbreviated version, and I actually started writing that. I had some of my day job to do before.
Do you have a further comment? Yes. Quick. I think the lady there would like to just.
This is related to the NICE initiative of PPI involvement fee, public participation involvement scheme. Were there lay representatives on this guideline development group?
Yes.
In that case, that would really be a very positive way of approaching NICE. And I just think that the NICE guidelines, they are produced in two forms. One is high, medical knowledge, and then the other one is a condensed version, which is aimed at Joe public and the rest of the people.
Yeah.
Yeah,
And
great.
he's sitting over there, so you'll hear from him later.
The old-fashioned idea of keeping the alkaline phosphatase level within the acceptable levels, does this no longer apply? Can the alkaline phosphatase rise considerably?
Yeah, well, what we said is we just don't have the evidence to clearly answer that question. We do address it in quite a lot of detail within that document, and because there were people around the table who weren't happy with a recommendation that said you really shouldn't. So we don't go that far, but we say you just don't have the clear evidence for benefit, particularly if you give repeated treatment courses from the prison trial. Nevertheless, there were clinicians there who felt they would want that alkaline phosphatase, preferably to get down into the reference range. Remember, even if it doesn't go down into the reference range, say with zoledronate, it'll often stay there still for years at a steady level. So, but as long as symptoms are better, our key recommendation is that's your primary aim. So it's not gone totally out the window, but we're making it clear that we don't really have the evidence to say to people, you've got to really try very, very hard to repeatedly treat until you get that test down to normal. We're saying that that's not generally what you should be doing, or it's not inevitably what you should be doing.
I mean, there's another point here, maybe Stuart will talk about this later, and that is that if you go back 30 years to when the treatments were first being introduced, the types of patients who were being seen by physicians had what we today would call very severe Paget disease with, alkaline phosphatases that were multiple times above the normal range. That's now very rarely seen, and it's become a milder disease and perhaps a less frequent disease. Stuart, I don't know whether you're going to address that question, but I mean, if you compare people who are getting treated today compared with 30 years ago, I think we would agree that they're probably rather different populations. Would you be happy with that?
Yeah, I mean, I think, while Mike has put it very succinctly, I think we don't know if it's beneficial to do that. And in the olden days, people were doing that. But since the olden days, we realised if you give too much bisphosphonates, you can do harm. You can make the bone more brittle, you get more side effects. And it's having that balance. So the main study was a PRISM study, a PRISM Easy study, and what that study showed, there was no benefit of hammering the alkaline phosphatase, and in fact, there were more side effects if you did that. So I think the issue is, and I will talk about it this afternoon, it could be different if you get very early on Paget's disease at the very start, and then and there is a study, there is a trial that's going to look at that, it's in progress looking at that. So if you have Paget's disease in your 60s, then there's no benefit in having your alkaline phosphatase suppressed, just for the sake of suppressing it.
Yeah, but we still, even with zoledronate, we still use the alkaline phosphatase to monitor it.
Yeah, exactly. But what I suppose we're saying is that you don't treat the alkaline phosphatase, you treat the patient.
Yeah. I think that's a
Good point to end on, yes.